So it's now live.
Okay, well, good afternoon, good evening, everyone joining from around the world, Africa and into Asia. Thank you very much for your continued interest in our teaching program. Today, we're very lucky to have Dr. Ángeles Montero, who's a cardiothoracic pathologist now at the Royal Liverpool Hospital. I've known Ángeles for many years, particularly from when she was in Manchester. I mean, I can't go through her resume in detail because it is so long, but she studied medicine in Madrid and then histopathology in Barcelona, where she also did her PhD. She did a lung fellowship in Arizona in 2009. And she's also worked as a cardiothoracic pathologist in many places in Europe. So she started in Barcelona. She's also done a locum pathology in lung transplant pathology in Newcastle. More recently, she's been in the northwest of England at Manchester University Hospital at Wythenshawe, which is our cardiothoracic centre. And about 2 years ago, she moved to Liverpool, Royal Liverpool Hospital. It's probably about 40 miles from where I am. And obviously a great coup for Liverpool to get Ángeles. So obviously with that, her experience is very vast, both academically and diagnostically. So we're very fortunate to have her today to talk about interstitial lung disease, which are a mystery to generalists. And I'm sure the pointers she gives us will help people making sense of the field. So without further ado, I'll pass over to yourself, Ángeles. Thank you very much.
Thank you very much, Richard, for this kind introduction. And thank you very much to all of you who wants to learn a little bit. So what I am going to do is, I don't know if you know, there has been a new update for the interstitial lung disease classification. It was published in 2025 as a conjoint classification from the European and American respiratory group. I am not going to deal only with that. I will talk about a little bit of the updates, but what I want is just to show you the way I read the lung biopsies. So I'm going to disappear, if you don't mind. Whoops. Oh, come on. I cannot see myself. Sorry, I'm lost now. So cancel. I cannot see the image, so I'm sorry. I don't know what I have done.
It might be an option to see if you can go back to webinar kit. Yeah, we can see you now again. And okay. If you can now see the button to reshare screen, might
I am trying just to see the presentation, but I can't.
So would that have been opened in PowerPoint?
In PowerPoint, yes, I do have it here.
Yeah, so maybe if you go back to webinar kit and then press share screen again and see if you can reshare
the screen, cancel, share slides. I cannot make disappear the camera. So share screen is said it's disconnected just now. I don't know why.
And is it that you want to turn off your camera, or?
Yeah, the camera, if I turn off, it disappears the presentation. So okay. I don't know why.
Ava, do you have any experience with this?
Yeah, it might be the camera might have to stay on when you're screen sharing.
Usually, yes. That might be that's the problem.
Yeah.
So I have okay, I do that. I open the presentation again. God, I could do it before. I cannot do it now. I wanted to avoid this. So I am clicking let's see, window. I think I got it now. Sorry about that.
That's okay. No problem. Yeah, we can see your share screen.
Okay. So I'm sorry. I am just new with this program. So I have no disclosures. My idea is just to make this presentation very practical. So I am going to talk about a little bit about definitions of ILDs, patterns and histological patterns and the differential diagnosis. And I think I have like 3 cases that we are going I'm going to share with you. So ILDs are a term that it has been accepted in the last update of the ILD classification, but what they prefer is the term interstitial pneumonias. Anyway, I like ILDs. I've been using ILD my whole life, so I will keep this terminology, which is accepted. So ILDs are a heterogeneous group of non-neoplastic, acute and chronic diseases which damage the lung parenchyma by means of different patterns of inflammation and fibrosis. So it's a non-tumoral pathology. It's mainly fibrosis and inflammation and affects the interstitium and the intraalveolar space as well, as we are going to see later. It has been classified always depending on the duration of the symptoms. So acute is when the symptoms in the patient, they are during hours or weeks. Subacute, they are considered for less than 3 months, and chronic when the patient suffer this pathology for more than 3 months. So interstitial lung diseases are more than 200 entities, and the only way just to learn about them is just to subclassify them and to create for us histological patterns. So we have interstitial pneumonias, this is the term, IP, interstitial pneumonias that include the typical ones. And now the most important are UIP, usual interstitial pneumonia, NSIP, non-specific interstitial pneumonia. And the third one that it has been, kind of accepted as a great pattern is BIP, is bronchial center interstitial pneumonia. But also are included other entities like DIP has changed the name, now is AMP. This is like a soup of letters that, I just going to tell you, but I am going to try just to kind of make it easier. So we have other entities like DIP, like this is the squamative interstitial pneumonia, now it's called alveolar macrophage pneumonia, RBILDs, a smoker-related disease, and others. We have also granulomatous lung diseases, and the most important is sarcoidosis. There are other entities we are going to see later. Other entities that are more rare, like Langerhans LAM, which is lymphangioliomyomatosis, histocytosis, pulmonary, amyloid, other entities, and at the end, pneumoconiosis, that we are not going to talk about them. So the last classification, it was published in 2025. This is a graphic that I have taken from the paper. And the most important difference is they have identified or they have recognized the entities as being secondary, primary, fibrotic, and non-fibrotic. They have subdivided the ILDs in interstitial lung disorders or alveolar filling lung disorders. Other entities that in the previous classification in 2013 they consider rare, they have identified as and included in the classification that were IPPFE, which is idiopathic pleuroparenchymal fibroblastosis and lymphoid interstitial pneumonia. And they have also included other entities that they were not clearly classified in the previous classification. So anyway, the classifications are very good, but we have to understand the way just to read the biopsy. And the most important is to know the anatomy, the architecture of the lung. So it is very important to understand or to know where we are when we have a biopsy. So it is important to identify the secondary pulmonary lobule. So this is very simple. So when you have a biopsy, the first thing I do is I look at the pleura at the surface. And from the surface, I try to identify the septa. So we have, here is this area that is bluish. In the center, we have the bronchovascular bundle. Normally you have a bronchioli, which is this kind of brownish circle, and then surrounded, you normally have two arteries. You are in the centrilobular area. The bronchioli and the artery, as you see in the graphic, they have the same size. And this is very important because if they are not in the same size, you have to start thinking that there is a pathology there. The veins and the lymphatics, they goes into the septa. The arteries and the bronchioli are in the centrilobular area. Surrounding the centrilobular area, you have the alveolar ducts and the alveolar sacs. So with that in mind, we just can go to the biopsy. So the most important, one of the first thing that I want you to understand is the classifications for the ILD. All the classifications, they were done in small biopsies. So when you get an explant, I am going to show you a lot of pictures of explanted lungs. It is very difficult to apply the same, even though we have to, it is not so straightforward because depending where you take the biopsy, this is going to, or you take the block, if you have an explant, the pathology you are going to see in the biopsy is going to be different. So for instance, if you have you see the circle in the upper lobes, in the upper segments, you are going to see fibrosis and normal, almost normal lung. So it's a patchy fibrosis. If you take a biopsy from the left, this is a right lung. So in the middle lobe, you have this in the lower lobe. In the lower segment, you have another circle. What you're going to have is honeycomb. So if you take honeycomb, this is not going to give you a lot of information. So it is very important to have an adequate biopsy. So what is an adequate biopsy for ILD cases? So the size should be more than 3 centimeters, and it has to be taken in depth. And if you have a biopsy that is less than 2 centimeters, normally this is a suboptimal biopsies. And what is very important is avoid areas of honeycomb. As I said, honeycomb is not going to give you information. You already know, and the radiologists already know, and the clinicians already know that the patient has areas of honeycomb. So we don't need that. So it is very important and it's very helpful, though I know it is difficult to discuss with a surgeon pre-biopsy. But if you follow this recommendation, this protocol, normally you don't have a non-diagnostic biopsy. If they give you only honeycomb, this is going to be insufficient just to give a useful diagnosis. So here we have another explanted lung. And I remember this case, and it was at the end it was an HP and hypersensitivity pneumonia. But what I wanted to tell you is, depending where you take blocks from this lung, the histology is going to be different. So in the upper lobe, you are going to have areas of fibrosis and almost normal lung. In this area is mainly honeycomb, and in other areas you have interface between the fibrosis and the normal lung. So it is very important to know where you take the biopsy. So it is very useful when you have the tray with the slides or the digital with all. You need to know where you have taken this biopsy, because if not, the biopsy is going to be very different. Is that like this painting or whatever? Depending, or these blind people, depending where they touch the elephant, their diagnosis or their thinking is totally different. So it is important to know where are you taking the biopsies, and the most useful is when you take the biopsies from areas of the interface, areas of fibrosis, but also normal lung. The normal, not normal, but almost normal lung is what is going to give you the information. So apart from the open lung biopsies, surgical open lung biopsies, that is the one we have in the upper left, we have other type of biopsies that can be useful. Transbronchial biopsies, the one in the center, they are very tiny. Sometimes they have this artifact secondary to the forceps. My experience with cryobiopsies, that are the ones that are in the right, are very, very helpful. Sometimes you don't need to say this is a UIP, a usual interstitial pneumonia, or an SIP. What they want to know is, what else do you see? Because this what else is what is giving them a lot of information about the diagnosis of the patient's symptoms. So I have been using, mainly because I went to Arizona to Mayo Clinic, I have been using these patterns my whole professional life because I thought it was the only way for me to learn learn how to diagnose ILDs. This because if you make all these 200 entities in only 6 patterns, and with this knowing which type of inflammation or cellularity, it helps you just to get at the end with a pattern and maybe a differential diagnosis. And this is what you are going to show in the MDT. So the patterns are 6. So we have acute damage, fibrosis, cellular infiltrates, alveolar filling, nodules, and minimal changes. But the most important is what you are going to find within these patterns. So if you see hyaline membranes, when you have fibrin, you have an acute damage. But also if you have eosinophils, this is going to give you a huge amount of information, necrosis, hemosiderin. So you subdivide, you know the pattern, then you go and with higher power, you know what you are looking at. And then you go to your book or your notes and then, okay, I have this, I have that. So maybe I can say a little bit more. So what I am going to do is I am going to guide you through the 6 patterns. I am going to show you different type of histological images. And with that, I am going to show you the way I just reach the diagnosis, the pattern, and the differential diagnosis. So here we have an acute damage. The acute damage, the most important thing you're going to see in the acute damage is fibrin. This fibrin can be lying in the alveolar spaces, which is hyaline membranes. Every time you think of that, you think DID, which is true. Or you have the fibrin inside the alveolar spaces. This is a new entity, but it's the same. It's like an acute lung injury, and it's called AFib, acute fibrinous organizing pneumonia. But anyway, this is an acute lung injury. The next picture, which is the upper in middle right, is an acute lung injury. But this is an acute lung injury that is organizing, because depending on the timing, you are going to see different patterns or different cellularity. The last, well, and the other 2 are also features that you can see in the acute lung injury. And you see a hyperplasia of type 2 cells, of pneumocytes. So be careful if you have a lung biopsy and you see this pneumocyte, that they can be very, very atypical. This is not an adenocarcinoma. This is a reactive feature secondary to acute lung injury. Or you can see squamous metaplasia. Squamous metaplasia are typically seen in cases with acute lung injury. So this is an explant from a patient with a viral infection, H1N1. And as you see, it's a diffuse condensation of the whole lung. However, depending where you take the biopsy, you take the block, the features are going to be different. And they are going to be different because the whole lung is not at the same stage. So you can have areas of the lung that they are more subacute than others. So depending on the timing of the disease, you're going to see edema the first day. So if the biopsy is taken the first day, you are not going to see fibrin. You are going to see edema. From 1 to 4 days, you're going to see hyaline membranes. From the first week, you see also inflammation. And then after the week, you're going to see fibroblastic proliferation. That's why in that picture, what you have is fibroblastic proliferation, because you have an area with more than 1 week of evolution. So the first finding that you are going to see in acute lung injury is edema, very closely inflammation in the interstitium, then fibrin, and then organizing fibroblastic proliferation. So here we have different pictures, and in all of them you have fibrin. So that's mean you have an acute lung injury. So, but in the first one, you have hyaline membranes. So you have a diffuse lung injury. It could be, in the last classification, idiopathic, if you don't know what the cause, or secondary to infection or whatever other condition. In the second, you have eosinophils. So you have an acute lung injury with eosinophils. Normally is eosinophilic pneumonia. If you have necrosis and acute and fibrin, the first thing you have to think of is infection. And the last one, where you have hemosiderophags, you have to think, you have just to start thinking in three mainly differential diagnoses, which is a diffuse acute hemorrhage, DAD in a smoker, where you have these macrophages with this kind of golden type of pigment. But if you look closer, you see these dots, the black dots, because of secondary to the dust. And it is very important just to know if the patient has cardiac failure, because you can see a lot of what is called now alveolar macrophages pneumonia, with a lot of hemocytic, and the only thing is that the patient is in cardiac failure. So let's go to fibrosis. The fibrosis is what we always think of interstitial lung diseases, and they're more complicated and difficult. I'm going to show you different explanations with different pathologies. The first one in the left is histiocytosis, and the one in the right is an NSIP, a non-specific interstitial pneumonia. So if I tell you that it's important to know where do you take the blood, is because if you give me a section from the lower lobe, and I see a lot of fibrosis, probably in the left picture, so in a patient with histiocytosis, probably I won't get anywhere. So the Langerhans cell histiocytosis is an entity that mainly affects upper lobes. So it is important to take enough blocks from the upper lobe and the lower lobe. In NSIP, you are going to see that well, it's not always the same, but it's a predominant diffuse pattern. And if you see this one, it's totally different. What you see is a predominant fibrotic pattern in the lower lobes and in the peripheral areas of the upper lobe. And in the center, you see that there is more or less a normal lung. So this is typical for UIP, or clinically what they call IPF. So the three typical features, histological features that we have to look in a UIP is peripheral and paraseptal fibrosis, fibroblast foci, and honeycomb. When you have these three things, the diagnosis it is UIP, usual interstitial pneumonia. In the explants, normally you have a combination. They said at 25% of cases, and it's true. So you normally in a patient with a fibrotic lung disease, you are going to find very easily a combination of both UIP areas with NSIP. But the diagnosis is going to be UIP in general, because the prognosis is worse in UIP, and this is what you have to say. But it is important that you describe what you see in the description. So ILD cases normally follows a typical protocol in which you have to describe quite extensively what you see in the biopsy, and then the diagnosis is a pattern, and then a comment with the differential diagnosis. The diagnosis is an agreement reached at the MDT. So we don't need to say this is that. No, we need to say the pattern, the differential if you can, and then the MDT is the one that is going to reach the agreement. So if you remember the previous pictures that I showed you, you saw this heterogeneous, what is called spatial heterogeneity, whatever. It's very nice, these words. But what it is one is patchy, the other one is diffuse. And this diffuse pattern in non-specific interstitial pneumonia could be cellular, like the one in the upper picture, or fibrotic. Cellular has better prognosis. It can be treated and normally resolves or evolves, but it can be treated. Fibrotic is the prognosis is similar to UIP. But if you remember the explanted lungs that I show you, the UIP, you see this peripheral alteration with fibrosis, while in NSIP is a diffuse alteration of the whole lung. And this one is the third explant that I show you. This is a pulmonary Langerhans cell histiocytosis. This is a bronchiolocentric interstitial pneumonia. This is the third pattern that has been considered like the third leg of the ILD in the result classification. What we have is in this picture, what you have is centrilobular fibrosis, normally affecting the bronchioli. And then you have this kind of, some people, they call it stellate, some others, they call it octopus, whatever. But what it is this inflammation associated with the histiocytosis. And it's quite characteristic if you find it in this stage. The problem with histiocytosis is it can evolve to a fibrotic lung disease, and the inflammation is lost. So sometimes it's very difficult because you cannot demonstrate the Langerhans cells. So if you see a bronchiolocentric in a smoker, of course, a smoker patient with nodules in the bronchiolocentric area with fibrosis and with this type of patchy type of alteration, you should raise in the differential diagnosis a histiocytosis as a possible cause, even though you cannot burn out. So if we go to cellular infiltrates, we have seen several. We are going to see fundamentally cases like this one. This is a sarcoid. No, this is, I think it was an NSIP patient with HP, but I don't remember. This is a diffuse condensation of the lung. In this patient, what it was an HP, a hypersensitivity pneumonitis, I remember now. And what you see in this patient, in this biopsy, is an increase of inflammation of the interstitium. So if you remember the lung is like a lace, is like a very thin alveolar space, is only one cell. So when you have more than one cell in the interstitium, you have to start worrying because this is not normal. In this case, you see there is an increase of inflammation in the interstitium apart from these aggregates that are typical in hypersensitivity pneumonitis. But what I want you to focus is in the interstitium, which is thickened. In this case, also you see that in the upper part of the picture you have the bronchiolar area. So we know that the bronchioli is at the top, more or less the same side that the vessel. I cannot see it very well. But you identify the bronchioli also because this is the only place in the biopsy where you should see a smooth muscle. So the smooth muscle is always surrounding the bronchioli, the terminal bronchioli. But in this picture, you will also see this peribronchial metaplasia. So it's this lining of the alveolar ducts and the alveolar spaces by this bronchiolar epithelium, which is not normal. This is indicating you that this is a chronic entity. But anyway, this is alveolar infiltrates. I am just going to talking different things. But and if you look at it, the whole picture is more or less the same. So this kind of lies within the term that I explained to you before, that is an NSIP. So it's a non-specific interstitial pneumonia, but in this case is cellular. So we have another picture here with the same type of features. And in this case, you have everything to diagnose HP, a hypersensitivity pneumonia, because in the bronchioli, if you can see it, we have a well-formed or a loose granuloma, non-necrotizing, which is typical in HP. So when you have this kind of, biopsy with increase of inflammation, you just go to high power and look at the type of cells that you have. So if you have lymphocyte and plasma cells, differential diagnosis is hypersensitivity pneumonitis, autoimmune diseases, chronic drug reactions, and NSIP. However, this is one of the things that you have to look at it. But you have to remember that not always or never an entity has only one feature. So for instance, hypersensitivity pneumonitis, you are going to find loose granulomas the same way that we did find it in the previous biopsy I showed you. But you also have to think of atypical mycobacterial disease when you have granulomas, or aspiration if the granulomas are peribronchial. If you have focal organization, if you have focal areas of organizing pneumonia, you have to think an infection in resolution, autoimmune disease, but HP as well. HP frequently have areas of organizing pneumonia. And if you have pleural and other entities of focal organization, of course, this COP, which is cryptogenic organizing pneumonia, is a term I don't like it because it's idiopathic. Cryptogenic is idiopathic. And even though it has been retained, this idiopathic, we always have to look for the cause. And chronic reaction to drugs, that you always have to think about it when you have focal organization or loose granulomas or inflammation. Drug reactions are always there. And the last one, pleuritis. When you see pleuritis, I always think of autoimmune disease. So it is very helpful just to know what you are. And you have this differential, and this differential you can add it at the end of the report. So these biopsies that I am showing, these are cryobiopsies, and they are very good. You don't have artifact. They are very, if the staining and the section is correct, they are very helpful. The first one is, it was an atypical mycobacteria, but I didn't say that. The only thing I said, it was a mild increase of inflammation in the interstitial and focal areas of granulomas. That the one, you can see the granuloma in the lower picture. I know it's an atypical mycobacteria because the blocks with granulomas were sent for PCR. And in this case, I don't remember the mycobacteria, but it was a mycobacteria. And the other one is very similar. We have an increase of inflammation in the interstitial, is bluish. You have also the centrilobular areas that are surrounded by inflammation. But the most important, there were some a foreign body surrounded by giant cells. And in this case was aspiration. But I wanted to show you the cryobiopsies, that they were very good and very useful for me and mainly for the clinician and the patient, just because they got the diagnosis. So if we go to the next one, which is alveolar filling, is the same way. So you just get the pattern and try just to see what happened when you know exactly what you have inside the alveoli. So the alveolar filling, this is the second subdivision in the new classification. And if you see macrophages, the term VIP is not used anymore, is AMP, which is alveolar macrophages pneumonia. RBILD is secondary to smoke. Neutrophils, acute infections, straightforward. Organizing pneumonia, resolving injury, always. However, remember, organizing pneumonia is not specific. And as anything I am telling you, nothing is specific. But if you just kind of gather all the information, you get to differential diagnosis. Eosinophilic materia, proteinaceous, eosinophilic materia inside the alveolar. You can think of alveolar proteinosis. Or hemorrhage, diffuse alveolar hemorrhage. And always please remember of chronic heart failure. And bone, which is a very, very rare entity. Dendrifold racemose calcification. This is a very, very odd, very rare entity. So the upper left, this is a cryobiopsy, and this was a patient. This was a biopsy from a transplanted patient, and this is one of the secondary PAP, pulmonary alveolar proteinosis. And this patient was taken the biopsy, diagnosed straightforward, and he just was clear with the lavage, and it was really a very, very successful multidisciplinary teamwork. The second one, it was also, this was the lung from a patient with a Legionella. And you see the necrosis and the inflammation. So every time you see necrosis in the biopsy with a non-tumor, of course, you have to think in infection. And viral infection is very necrotic. Organized pneumonia is this plaques of fibroblast that they are occupying the alveolar spaces. This is a cryobiopsy as well. And when you have this is another cryobiopsy, and even though it seems very dramatic, this patient had a cardiac failure. Nodules. Nodules are quite frequent, and you can see a lot of type of nodules. Nodules can be seen with granulomas, with lymphoid tissue, with necrosis, with cancer, with histiocytosis, with organized pneumonia. So nodules is something that we see quite frequent. And this is an expand lung from a sarcoidosis patient. This is the left lung. And only with this image, you can see that the inflammation, the fibrosis is mainly centrilobular. These entities with centrilobular, they are now accrued in a new term, which is bronchiolocenter interstitial pneumonias. This case was a sarcoidosis, as you can see. But if you see granulomas, you have to think also inhalation. You have to see not HP in this case because it's too much. So granulomas for hypersensitivity pneumonia, they are not so well formed. But you have to think in sarcoidosis, berylliosis. We shouldn't forget that. So sarcoid and beryllium, they give the same features on histology. Drug reaction, they can give you granulomas. So the differential is quite extensive, but it's very helpful when you have the information and you can give them, the differential. So with granulomas, infection, sarcoidosis, aspiration, berylliosis, drugs. So this is the more common, but you have some more. Lymphoid tissue, you have to think on lymphoid hyperplasia, and they have to exclude lymphoma, necrosis, infection, tumors, GPA, vasculitis, atypical cells, infections and tumors, and stellated scar, Langerhans cell histiocytosis, and organized pneumonia. Again, persistent pneumonia, but it can be associated with other entities like HP or any other. So every when you see organized pneumonia, you have to think that there was something there and it is organizing. So you don't know. Even in a cancer, you can have a nodule in the lung and it's surrounded by organized pneumonia. So organized pneumonia is very, 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 very frequent. So here in the pictures you have in the upper left, just the same. It's very similar to if not the same, picture that I showed you before. This is a histiocytosis. As you see, is a centrilobular scar with inflammation. You identify the bronchiola. Normally, the lesion that you see in histiocytosis is mainly bronchiolar. Is because of it's related to smoke. So some of is the damage that the smoke is doing in the epithelium, and is produced these areas of fibrosis and dilation of the bronchioli. That's why in the radiology they can see cysts and cavities. The second one in the upper right, this is a rheumatoid nodule in a patient with pneumoconiosis. So this is a Kaplan syndrome, and it's very typical because you can see this necrobiosis in the center, and it's surrounded by this kind of band or of brownish And this is very typical. This is very typical in Kaplan syndrome. So it's rheumatoid nodule. The lower left is a follicular bronchiolitis. This is an entity that, in my experience, is diagnosed by the radiologists very well, because they have this 3 and bad in radiology. And it's very nice to see in the biopsy, because you see these aggregates, lymphocytes. Not only aggregates, is the typical is these follicular lymphoids with germinal centers in the center. So surrounding the bronchioli. So the bronchioli, there are bronchiectasias normally because they are dilated. So you're going to see that the bronchioli is bigger than the artery and is surrounded by these follicular lymphoids with germinal centers. So it's a really very nice and very helpful, and is associated in many patients with connective tissue disorders. And the third one is the typical one. This is a tumorlet, even though it doesn't look like, but the size was less than 5 millimeters, and is the typical nodule that when you see it, you say, well, this is a tumor. This cannot be any other thing. So the last one, minimal changes. For me, this is I think the most difficult, because you have to think, or this is a sample problem. Sometimes it's because they didn't take from the right place. This can be a small airways disease, vascular changes, or if you see cyst, well, if you see cyst, you know that this is the problem. But you have to think, or is a problem in the airway, or is a problem in the vessel? So, and with that, you have to help you with special stains, normally EVG, more than trichrome. For me, the EVG is the most helpful stain overall for this kind of changes. So, for instance, here you have this image where you look at it and you think, well, I don't see anything. Yeah, but if you look at the image that we have in the left-hand side, it's a very, I remember Professor Leslie told me this is like an osteoporotic lung. It's a lung that is kind of, you need more, you don't see the interstitium clearly. You are losing the interstitium. And mainly because I don't see where is the centilobular area. So if you don't have a bronchioli, you have to start thinking that there is a problem in the airway. In the other picture, in the one in the right, the upper, you see that the bronchioli is very dilated. So, and you compare with the artery, is dilated, so you have a bronchiectasia, and this bronchiectasia is telling you that somewhere there is an obstruction of the bronchioli. So this is very, very useful. Sometimes you don't see it because it's not in the biopsy, but it's telling you that there is an obstruction somewhere. And the one in the lower is obliterative bronchiolitis. This is a transplant biopsy. And what you see is the artery. And I know the other one is a bronchioli because I have the artery. So that's why it's so important to know where you are, because with that, you can give a diagnosis. So in the 2013 classification, we can go later a little bit deeper in that. And there were 2 entities that they were considered rare. And now they have been accepted as a new, as a normal, an accepted entity. One, it was the idiopathic or secondary lymphoid interstitial pneumonia, and the other one is pleuroparenchymal fibroblastosis, primary and secondary. Unclassifiable IPs depends on the consensus of the diagnosis. So this is another thing. And then they identified other rare histological patterns. One, I already talked about this, and this was acute fibrinous organizing pneumonia. This is an acute lung injury, but instead of having hyaline membranes, they were inside the alveolar spaces. And imagine, it was a rare histological pattern in 2013, and now it's identified as one of the big patterns, these bronchiolocentric patterns of IP. So this is the case of NSIP and LIP. NSIP is non-specific interstitial pneumonia. In this case, is cellular. In the left, in the right, you have an LIP. And the histological differential is mainly the amount of inflammation of lymphocytes you have in the interstitium. So sometimes it's very difficult just to say, when do I say that? Well, it's when I think it's too much. And normally LIP is associated with connective tissue disorder, for instance, Sjogren, autoimmune immunodeficiency. So normally they are all associated with a very specific clinical picture, while cellular SIP can be associated with a lot of things, but not always connective tissue disorders. So LIP, for when you have an LIP, of course you have to exclude lymphoma, or you have to exclude other diseases like HP. HP is hypersensitivity pneumonia, sorry. But in my experience, I never had such a huge amount of lymphocytes as you have in LIP. So LIP, it was considered in the last classification of a very, very odd entity, idiopathic, and even they start thinking of just eliminating this entity because they thought it was too rare. Idiopathic, very rare. This is one of the papers. But if you see, it can be associated with certain type of infection, very frequently collagen vascular disease, overall Sjogren syndrome, rheumatoid arthritis, lupus, immunodeficiency, all related disorders, immunological disorder, and always drug-induced toxic exposure. Drug-related alterations in the lung is always in my background. So here we have an explant of, in this case was idiopathic pulmonary pleuroparenchymal fibroblastosis. This is the best explant I have seen in my life. So you see that this is this is quite infrequent entity, even though it is, I can diagnose it more frequent when I learn, you start diagnosing more and more. But normally it is diagnosed by the radiologists, where they see fibrosis in the upper segments of the upper lobes. But what they see in the radiology, that is this condensation, this fibrosis is extending to the centrilobular areas and affects peripherically the lobes of the lungs. In this case, the patient was transplanted. It is for me, the most helpful stain is EVG, and that's what you see in the right lower image. So you see a very black. If you have this kind of EVG, it's very black. And what you see is accentuation of the alveolar spaces and intraalveolar fibrosis. Please don't make this diagnosis if you have a smoker with an apical cap. The histological features are identical. However, in the apical cap is an apical cap. So you have this type of fibroelastosis in the upper lobes. It is limited. However, it can be extending a little bit. So don't make a diagnosis of PPFE if you only see that. You have to say that what you see is an apical cap in a smoker. But if they tell you the patient is not a smoker, you can raise this possibility. But it has to be a correlation with radiology just to make this diagnosis. So another one, it was considered as a new entity, it was AFib, and this is an acute lung injury, as I told you, is straightforward fibrin inside the alveoli. In the explants, I saw this reaction in antibody-mediated rejection, so it's a very aggressive type of acute lung injury. It could be seen in other entities as well. And in the upper right, what you see is an organizing AFib. But this is exactly the same that what I have explained in diffuse alveolar damage. So depending when you take the biopsy, in this case, you are going to see different patterns. It doesn't mean it's not the same entity, it's the same, but depending on the timing, the histological features are going to be the same, different. And as you see in the radiology, is a white lump in diffusely. DID also is a diffuse entity, but but normally it's patchy. So it doesn't, it diffuse because it affects the whole lung, but it doesn't mean that if you have 2 or 3 segments, 2 pieces, you are going to expect to have different patterns or different type of histological features. Don't expect to have the same thing in 3 of them. So the other one is the airway center interstitial fibrosis. This is what is called now bronchial center interstitial pneumonia. It has been, this entity was present in the first classification in 2002. It kind of disappeared in the 2013, and then it has come back. Why? Because there are a lot of entities that they affect the centrilobular areas, and we didn't know how to call it. So now with this pattern, you can say, okay, what I have is an entity that is affecting the centrilobular area. In fact, I remember I did a study where I have this bronchial center problem, and I call it atypical UIP. And with the clinician, we all understood what we were talking about. So with this, now we can say, okay, I have a bronchial center interstitial pneumonia. I remember a long time ago, this was considered mainly related to hypersensitivity pneumonia. Hypersensitivity pneumonia, it is a condition that normally is related to an inhalation of an allergen. Sometimes you find it, and in many occasions it's very difficult to find. But what you have is an alteration of the centrilobular area. But there are other entities that they produce the same histological pattern, and that's why they have kind of retrieved from the sac this entity that it was present a long time ago. So let's start with the. I think I'm talking too much. Anyway, we have only 3 cases. I will try just to go quickly. So we have an 18-year-old present with 1 week of rapidly progressive shortness of breath. So it's rapidly progressive and is 1 week. So we know this is acute. It's accompanied by night sweats and fever, and he's hospitalized and required intubation. And the chest imaging show bilateral asymmetrical ground glass opacities. So we know it's a very young patient and is an acute entity. You have a ground glass opacity that are distributed in both lungs. I can add that they are normally migratory. They appear and disappear. Normally they treated with antibiotics and they don't respond. So, and they give corticosteroids, sometimes they won't appear, and that's why they do a biopsy. The biopsy, what you have is a diffuse condensation of the alveolar. So if I see that, okay, the first thing, pattern, this is alveolar filling. Why? Because I cannot see anything. So it's very diffuse, very condensed. So my first thing is, okay, I have an alveolar filling pattern, even though I have some areas in where I have some thickening of the interstitium. But I know that acute lung injury, the first phases, remember, is edema and inflammation. So I have fibrin, I have these areas of thickening that I think everything is related to an acute lung injury. And I go to higher power and I see eosinophils. I know there are other cells, but this is very distinctive. Having eosinophils, it gives you a clue. So this is acute lung injury. I have hyaline membranes, not really. It's more or less, a diffuse pattern, mainly AFib, but I have eosinophils. Necrosis, I don't, and siderophils either. So I think eosinophils is going to give me the clue. And I go to the diagnosis, and in this case, it could be granulomatous infection. No, I don't see granulomas. I don't see vasculitis. It could be acute viral pneumonia. It could be, but in my thought, I can give the differential diagnosis, but I would go for eosinophilic pneumonia. Eosinophilic pneumonia is the 3 features that I always look for is fibrin, macrophages, and eosinophils. Of course, you can say others, you can say this, you have to exclude infection, you have to exclude eosinophilic granulomatous, but I always write my differentials in order. So if I think this is a eosinophilic pneumonia,